everybody, and thank you for being here, and thank you to CVI for giving me the chance to present something which I think it's very important for us who are, still early into the practice but have some experience to talk about cases like this. So thanks to Dr. Pinto, Zabur, and Dr. Enderfeld for being the panelists. So this is the case which me and my colleague, Dr. Chandra Ojha, who is a friend and colleague, so we are in Texas Tech. We arrived there to build the CHIP program. This is very important because as we go through it, we all have to realize that when we come out of the fellowship, especially when we come out of the fellowships where we have a lot of hands-on training, fortunate to have good skills, you come out with a lot of confidence, a lot of enthusiasm, but how life can unfold. So the reason why I have kept few dots because heartbreak is always bad. If you spoke to me like 10 years back, I would say the worst thing which happened to me in life was my heartbreak. But now if you ask me, I don't even give a damn about it, because as you do more and more, you realize that there are worse things which can happen to you, and probably happen quite frequently. So this is a 82-year-old female, and I live and work on the border. As I say, I'm guarding the fort. So there's a lady from Mexico, actually, and she actually came in here. We do have a language problem, but we have a lot of people to help us out. So what we found out was that this was her clinical details, that this lady was quite symptomatic. She underwent exercise, MPI, and as you can see, at very low, I'll bring it up, sorry.
Go ahead.
And at a very low workload, she's very, very symptomatic. And she has reversible ischemia in the LAD territory. This was a high-risk positive MPI for ischemia. She has a left dominant system. Diagnostic angiogram was done by one of my partners who doesn't do any complex coronary interventions. So he asked for me to help him out. So this is just one of the angiograms. We had quite a few, but I will show you a better one as we go through the interventional. Now, at this point, to me, it looked like, okay, this is Medina 111, and there is a trifurcation classification as well, as we all are aware. And actually, the author who brought it out in 2007 is one of our panelists in some other meetings, in some other talks. So I didn't think that it's a trifurcation disease. I thought it's a bifurcation disease at this point. And then we did follow the heart team approach, and the surgeons, turned her down, and then we decided that, okay, if her aortoiliac vessels allow us, we should think about doing a impella-assisted PCI in this lady. So as you can see, this is beautiful. It doesn't get better than this if we want to use an impella. So we are pretty happy with that. And standard techniques, ultrasound guided. But then what we encounter is that she has a very tortuous aorta. Not a big deal. We actually, I'm sorry about this. So basically we got a 7 French axis because at this point we were not completely sure about what's our bifurcation strategy going to be. We were not very enthusiastic about DK crush. We were more thinking about mini crush at this point. But once we went in and took the pictures, I can probably say this, and I hope a lot of you would agree, that actually the bifurcation disease looks more complex than what we thought on the initial coronary angiograms were. But I am able to convince myself that it's not a trifurcation. Still, it's a bifurcation. But ramus is a good-sized vessel. I cannot afford to ignore ramus here. So, everything is going well. 2 of us are working. This is early in when we are building the CHIP. This is a new CHIP program. We're taking every step to make things successful, not have complications. And as we all have anxieties, no matter how much of experience you have, what you have done, when you start venturing out into doing things which has not been done, we all have that. So nothing to hone about, just the standard techniques. We use triple wire, and that was the big reason why we had the 7 French, so as not to be jammed and struggling through the procedure. Everything seems to be going well, and as you can see, and this is the first thing. So if you ask me how did I manage to do this, it's my fault. I was probably trying to rush through it to do the mini crush, and I had a geographical miss. As you can see, I thought that I was landing it perfect, but I missed the ostial LAD. Okay, this can be salvaged. Not only me, Dr. Chandra is also very experienced. So we do manage to do what needs to be done. Things are looking better. Nothing to worry. And at this point, I'm like, okay, good. And this very satisfying, right? So, but the moment of happiness and accomplishment lasted only for a fraction of a second, because the first thing we look at is the left main. And yes, we do have some snow plowing into the ramus, but we have good flow, so not really concerned about that. But then, what's happening in the distal LAD? And the question comes, how did that happen? Well, because we had real difficulty getting through the stent into the ostial LAD, and I think the wire, although it was in our view field, but we magnified too much to make sure that we don't, for the lack of better words, and pardon my French, screw it this time, we actually were not looking at the distal tip of the wire. So for people to learn, the basic things, you have to have your guide wire and distal tip of the wire into the focus. You cannot afford to lose that focus. Anyway, so feeling frustrated, but managed to successfully cross, sorry about this. And then, just a prolonged balloon tamponade. And I think at this point, many of you would agree that, yes, I have a linear flow, I have a linear dissection, but it's not flow limiting. And I don't think it's going to cause any compromise of my beautiful, which I can call at this point, distal left main bifurcation. So I'm feeling happy. The team is feeling happy. So this is the thing, that the sutures, this is what happened to us. And I am an EVAR operator. He is a TAVR operator. We do wide bore access, and also not that we are short of experience, but that just wasn't our day. Something kept on going wrong. So we took the destination sheath out, replaced it with a smaller sheath. 14 French sheath was peeled off. Workflow sutures broke. I cannot explain to this day why. The iliacs look good. The CFA look good. We both are experienced wide bore closer. Like life humbles you, and like we both are tried multiple tricks and all that, and we have been in this situation many times. This is not our first Russian roulette, if you call it. But anyway, at this point, of course, we had a lot of discussion. We are having a big hematoma. Thankfully, we had cath lab staff which was able to hold it well. Should we reverse or not? And actually, I was very much concerned about that apical LAD, which I had dissected. If I go on to reverse anticoagulation so soon, will that be compromised? Sorry. And then I crossed over. We did the internal and external tamponade. And then, just when we thought that things were going well, actually the patient becomes hemodynamically unstable, goes in shock, and this is what we did. We upsized to 8 French because we had a oozing and all, echocardiogram. We are looking for causes of hypertension. We can't find it, and then this is what we see. We have a profunda perforation, and we actually did cover it with a covered stent, the distal vessel flow is really bad. But unfortunately, this was a very sad outcome. And despite whatever we tried, we kept on dealing with one problem after another. But at the end, unfortunately, we lost the patient because the patient actually was having GI bleed, which we never figured out till NG tube was put in. So from the learning perspective and for the panelists, I will stop here as they say that if you look back, you gain more insight. And these are the insights which I got.
So first of all, I'd like to commend you. It is extremely courageous to show a complication case like this, especially when the patient dies. I think a lot of these what-ifs are what we go through after we have an outcome like this. And I don't have anything incredibly smart to say, so maybe I'll turn it over to my panelists.
Chandra, very complex case. Congratulations for initially great results. Unfortunately, she didn't make it. This is an example of how sometimes if we try to be more careful and do more things, we could sometimes harm patients. In retrospect, maybe it's easy to say, why did we use an impella? You're wondering, things were getting wrong, you didn't know why. It's probably she's 81 with tortuous vessels. That's why things were not doing well. I would have probably not used an impella in this case, but again, it's a retrospective view. In general, I'm a proponent of be as simple as possible. Older patients, just simple, maybe just treat the mid-LAD, left main, and get out.
I agree with the comments. What was the EF?
EF was normal, 55%, no wall motion abnormalities to begin with.
Yeah. I think it's always, in retrospect, easier, but I would share the sentiment that, if you don't need to go large bore, femoral, with a 7 French slender or even a sheathless catheter, radial, no support, less vascular complications, it would be the only comment, but a very nice case.
And that was my main purpose of bringing this case, because, we all are very well-trained, very enthusiastic, aggressive, want to do more. But when things like this happen, when things are going good, things are good, but an interventional cardiologist is only known by the last complication. So when these cases make you look back, do I really need to go high guns on everything? Do I need to put out everything what I can, or can I do sometimes things simply? And I think as we do, and that's why experience, comes into play. If I have to do this now, I would actually not use impella, and I would do what you said, 7 and 6 slender, and try to do that.
So I think trying to maybe go down the what-ifs, I think we took care of bullet point 1. I think the bifurcation strategy is always dealer's choice. I don't think that really makes that much of a difference unless you're dealing with a shock patient, in which case that's basically the only time I use simultaneous kissing stents. I think the peel-away sheath is something that's underappreciated. We're exhausted, we're done with all this stuff, and it takes really kind of 2 people to do it properly. So if you just peel it away by yourself, you either move the impella or damage the arteriotomy. I think the external iliac balloon occlusion, these are standard techniques for large bore access. You were kind of screwed when the profundo was ruptured, so you had to stent across that with the covered stent to deal with that. But you could think about repairing the groin and that sort of stuff surgically, but they would have never taken her. And then it's just so weird that she's bleeding in the stomach like this.
The other comment is, you had was it a pilot 50 in the LAD?
Yes.
Was that switched for a workhorse?
Yes, it was.
Okay.
Run through, and so my workhorse is run through, and I do make sure, and I have done lots of chip after this, but I never ever actually work with a hydrophilic wire in the distal vessels. Yeah.
There's actually a term for what you're describing of when you were zoomed in. It's called intentional blindness.
Yes.
And you're so focused on something that you don't even see what else is in the picture. Even if you have the distal wire in the picture, it could have been out and exited, and you don't see it because you're worrying about something else. And it is something, the more complicated the case gets, if you felt this, just recognize this situation and get yourself out of it, of the tunnel vision. you will miss things because you're getting so stressed out. And that's why doing 2 operator cases is so beneficial, is because usually you fatigue or get this tunnel vision at 2 different times. But when you're in a case like this, both of you are stressed out.
Yeah.
So,
And also one thing is there that if you move to a new place, start a new job, no matter what you have in the last place, your accomplishment and all doesn't count, because you are going to be nervous. You are going to be psychologically stressed out because you have to prove and reprove yourself. And that I didn't think was going to be such a big deal, but it turned out to be a little bit.
Just have it come.
Uh-huh.
For a case like this, I believe, we learn from our mistakes or past experience. I believe taking such a patient to the camera without a clear plan, like, I'll see what I will do. I don't believe this is the right thing to do something like this. And probably, if you had IFR strength or awareness, I don't believe that they would have been positive. So probably just straightforward. I'm not even sure what the mean needs to be standard. Just it's a T angle, 90 degrees, straightforward, proximal stent, then mid stent or mid and proximal LAD and
And I completely agree with that. And that's why I gave this disclaimer, although it's an embarrassing thing to say, but maybe my enthusiasm to do a chip case in the beginning of establishing a chip program got better of me than whatever wisdom or reflective thinking I had. And and I'm the one to take full responsibility for it. But I hope I can give this to other people that, hey, when you have time, please take a step back and look at the bigger picture, because sometimes when things go bad, then you are left with what ifs, which I have at this point. And this case haunts me, not that I have not had complications, the complex things I do, I will have. But this case haunts me more than any of the other complications which I have had, exactly for the reasons which you all have mentioned, that maybe I did not do my groundwork as good as I should have done.
well, again, as I said, this is very courageous. I think you gave us some very special learning points, and these are the most difficult cases to present, and you learn the most. I think it's always fun to talk about how to shape a wire or something like that, but I think we can all take something from this case. So let's, in the interest of time, thank you very much. Let's move along. So I'd like to invite up Michael Gerges, complex high-risk PCI.